Are we live?
It'll take a few seconds, Mark. Right, you're on.
Are we on now, yeah?
We're
Yep.
live, Chair. Yeah.
Thank you. Good evening and welcome to this virtual meeting of the Health Scrutiny Committee, held by virtue of regulations introduced by the government in April 2020. I'm Councillor Shoaib Akhtar and I will be chairing the meeting. The regulations have temporarily removed the legal requirement for local authorities to hold public meetings in person, but enables councils to still make effective and transparent decisions on the delivery of services for residents. If a connection to a member is lost during this meeting, I will stop the meeting to enable the connection to be restored. If the connection cannot be restored within a reasonable time, the meeting will proceed, but the member who was disconnected will not be able to vote on the matter under discussion, as they would not have heard all the facts. Should any aspect of the external link fail, I may call a short adjournment of up to 5 minutes or so to determine whether the connection can quickly be re-established, either by video technology or telephone in the alternative. If the connection is not restored within that time, the meeting will be adjourned and any further business will not proceed until another time and date. Firstly, can I ask the clerk to ask the members to confirm their attendance, please?
Councillor Byrne.
Present.
Councillor Hamblett.
Present.
Councillor Ibrahim.
Present.
Councillor McLaren.
Present.
Can I just check whether Councillor Elias has joined us?
Can't see him.
And Councillor Akhtar.
Present. We also have representatives from Oldham CCG along with council officers in attendance. Later this evening, we'll be joined by a representative from Croynes and Colitis UK for one of our items. If the committee is required to take a vote on a report for approval, or if we are making a substantive recommendation, each member will be individually asked to state whether they are for, against, or abstaining. When a report is for noting, I will only ask if any member does not agree. As with all committee meetings, should it be necessary to exclude the press and public, once the exclusion has been moved and agreed upon, the press and public will no longer be able to view the meeting. Can I ask members who wish to speak to please indicate using the chat function? If we can now turn to the agenda, and for the benefit of those members of the public watching, the full agenda is available on the council's website. Item 1. Do we have any apologies for absence?
Apologies from Councillors Cosgrove and Tour, Chair.
Thank you, Mark. Those are noted. Item 2. Do we have any urgent business?
I'm not aware of any urgent business, Chair.
Thank you. Item 3. Do members wish to make any declarations of interest? No. Moving on to item 4. Have we received any public questions?
No public questions received, Chair.
Right. Item 5. Members have before them the minutes of our last meeting held on 13th of October. Are these agreed as an accurate record?
Move the minutes, Chair.
Thank you, Councillor McLaren. Does any member not agree? Thank you. The minutes are agreed. Item 6. We have the minutes of the joint meeting of scrutiny committees held on 24th of September. Can we note these minutes?
Agreed, Chair.
Yeah. Does any member not agree? Thank you. The minutes are noted. Item 7. We have the minutes of the joint scrutiny panel for Pennine Acute Trust held on 15th of September. Councillor Hamlet was in attendance. Councillor Hamlet, do you have any comments on the minutes?
No, I'm happy to move, Chair. Thank you.
Thank you. Can we note the minutes? Does any member not agree? Thank you. The minutes are noted. Item 8. We have the minutes of the joint scrutiny panel for Pennine Care NHS Trust held on the 22nd of September. Councillors Hamlet and McLaren were in attendance. Do we have any comments on the minutes, councillors? No?
Move the minutes, Chair. Happy to note the minutes.
Thank you. Does
Second
any member not agree? No? Thank you. The minutes are noted. Item 9, we have a presentation on the CCG's primary care strategic priorities for 2019 and 20 to 2021-22 for consultative purposes, as set out on page 47 of our papers. To make the presentation this evening, we have Mike Barker, our Joint Strategic Director with the CCG, and Nicola Hepburn, the CCG Director of Commissioning and Operations. Mike and Nicola, could you please introduce yourselves and present the report to us? Thank you.
Hi, Chair. So I think you've just introduced me and my job title, so I won't go back over that. If I do a very quick introduction, really, it's a bit of a seminal moment. This, in many ways, I've been in Oldham now for 2 years. Nicola's been in Oldham for probably about a year and a bit, just over, and we both walked in to Oldham without there being a primary care strategy in place, which I just find a little bit odd, really, for a place. And we've spent the best part of a year really trying to get underneath the issues in primary care, and then obviously COVID hit, so it slowed us down a little bit in bringing forward this today. But what we're looking to do is put on the table a series of what we think are the major priorities for primary care to help shape that strategy, rather than just bring a kind of baked strategy here. It's important to really set out from the start that Oldham, like all 10 localities of Greater Manchester, operates a locality plan, and that's the plan that brings together health and social care delivery priorities for the next 5 years into a single document. There's a very clear vision set out in there, which broadly is about making sure that Oldham's a vibrant and thriving place, and where well-being is prominent, and where health and well-being are focused and tackled upon. I think it's really important that the development of any strategy for primary care is absolutely set in that kind of context. We need to be focused now more than ever on tackling health inequalities, reducing the gap between the most deprived and the most affluent, and the services that are organised in those kind of ways. But equally, we need to set that out in context of the national landscape of the way in which the NHS is travelling. And that NHS broadly is now focusing very much on the development of primary care networks, put simply, the collection of GP practices in geographic places co-aligned with local authority district boundaries, making sure that we get the services aligned and arranged and the leadership model in place to make all of that happen. What we've tried to synthesise then is a combination of the commitments that we made in that locality plan about 18 months ago, all the expectations that are coming at us nationally from a variety of different documents in the NHS, and brought forward today into what we interpret as a set of priorities. But added to that, we've then taken what we think are some of the kind of fairly significant barriers that we think we need to tackle. And we're just about starting a piece of work now on things like population health management, and really bringing a different type of intelligence and insight into Oldham. Much of that's credit to the work that Nicola's been involved in with the team, and starting to get underneath the actual reality facing some of our communities and some of our primary care networks. And it'll come as no surprise, I'm sure, to members that, you know, when we look at some of the detail of underlying ill health, you'd expect there to be around about 5 or 10% worth of complex issues in some of our localities or some of our neighbourhoods. What we're now starting to see is that number's as high as 40% in some places, especially where deprivation's high. So the challenges that we want to address through this approach is not putting a one-size-fits-all strategy in place, but more of an approach to delivery of primary care that's unique and sensitive to the needs of the communities by which we organise our services, and that's on 5 neighbourhood-based footprints. So it's with that context that I'll hand over to Nicola, and she'll delightfully walk us through what that looks like in priority terms. Thank you.
Thanks, Mike. Thanks, Chair. Evening, everyone. Good to see you all again. So Nicola Hepburn, as introduced, I'm the Director of Commission Operations. So as Mike said, this is based very much around the Oldham Cares locality plan. This has very much been done in conjunction with all of our partners, but these and the presentation that you've received is around the priorities for primary care. What we've looked at, and we've been very honest in our approach to setting out our strategic priorities, is looking at how do we actually improve from where we are. So we have a quality strategy, and we go out and we've worked around how do we improve quality, how do we get a good assessment, and we've talked to you previously around getting a baseline assessment of the real quality and safety of practice within primary care. What that's highlighted is that we've got some challenges very much around our workforce, and so we've got one of the priorities is around driving up workforce, looking at alternative work and roles within primary care, so not just looking for GPs, looking at other professionals that can support and address the inequalities for our population. We've also looked around estate. So although we have some reasonable estate, we're very fortunate in Oldham. We've got a lot of new builds where we've got those that do need improved estate. Actually, how do we bring them up so everyone's at a good level? So improving our digital access, certainly in light of COVID, being able to give everybody that access. I know later you're looking and talking to other members of the team around the LD and the mental health strategy. But actually what we've started to look at across general practice is actually people that are unable to use digital access. So for people with very long-term chronic mental health, cognitive impairment, learning disabilities. So actually, how do we accomplish making sure that they have their health needs met? We also have looked at how do we get primary care at scale. There's a lot of single-handed practices. How do we get people across the PCNs to work together across making sure that smaller practices are joined up with all of the health and social care services across our whole of our system to make sure that nobody goes without, and that make sure that referrals happen in a smooth and transitional way to make sure that people aren't waiting on long waiting list within secondary care, understanding that the challenges that they have in the hospitals as well. We've looked at how do we do long-term condition management. So we've been working with Mark Warren around the social work and how do we do preventative services and making sure that we've all linked into that. And then looking at how do we start to reduce inequalities by doing non-incentivised measurable outcomes. So we're not funding these improvements because actually there are things that we should do nationally that we are under delivering on, and actually how do we start to drive up the population health and the outcomes for our citizens by actually doing some real challenged focused work within each of those primary care. So you'll look at that around we have a real issue with learning disabilities, people with mental health, how do they access, people with cervical screening, and the people that are actually down as refusing. So how do we start to improve our cancer outcomes, and how do we start to improve those long-term conditions? And that's what this strategic priority document's all about. So I know you've had it, I know you've read it, so to give you opportunities if anybody's got any questions.
Do any members have any questions or comments? Councillor McLaren.
Thank you, Chair. This, in a sense, this is like a sort of mini version of the Northern Care Alliance. We appear to be talking about three things, as you know, in terms of staffing, services, and estate, as it were. And one of the things that I am interested in really is what situation we are in terms of staffing, whether there are any gaps, number of vacancies, etc., what problems we might face in that respect, and how that then equates to the pressure on services that might be available to the wider community. And you've touched on estates yourself, Nicola. So I would be interested to know exactly what the nature extent of the situation is in terms of availability of buildings and the need to refurbish, replace, etc. that we might be faced in the future.
Okay, so we have a full workforce plan, so we know that where there are gaps, we know that where we need to do specialist recruitment, and we're working with the colleges and the universities to do some alternatives, so not just focused, like I say, around GPs, but actually how do we get pharmacists linked into practices to improve prescribing, how do we get advanced nurse practitioners, and how do we start to do a whole system workforce. And I'm more than happy to share the kind of the highlights of that. I've not got that on me directly today, but certainly can share that through Mark for you to make sure that you've got that. From an estate perspective, similar, we are in a good place. We've got a lot of new estate across Oldham, and I can see you know there are some twinges. We're in a better place than other areas across GM. It's one thing for us to have some pride in, but there are some areas that we do need to do some focus work on, and that's some of the challenges that we're working with in PCNs around smaller practices that own their own building. How do we make sure that funding is flowed through? How do we make sure that they're accessible? And actually this is some of the challenges that we have with some of the partners of the GP practices, because actually we can't impose some of those changes. It's about how we work with them to make sure that they get done, and that's, you know, that's another situation that we need to work on. But it's again, I can share that the what our position statement is around the estate.
Okay, thank you. Yeah.
Just on the challenges on the estate in terms of working with some of these partners, where obviously if you get a GP sort of service that's not basically doesn't want to do any improvements, do we have any, I don't know, penalties, or what can we do? What are our options available?
So it's common. I suppose we need to get into some of the detail with that question, Chair. You know, fundamentally, GPs are independent business practices. Yeah. Fundamentally, we can incentivise the amalgamation into single consolidated estate. We can penalise for the non-delivery of standards under the contractual arrangements, but ultimately the power lies with the regulator to do very dramatic things. The only power the CCG has is the contract. The professional standards regulation goes with the CQC and the GMC. So there are only a certain amount of things that we can do. I think really the framework has been set to bring primary care together into networks that doesn't necessarily enable or require them to give up their individual contracts, but does require them to work collectively together. And what we are setting out here, that's perhaps a little bit implicit in this rather than explicit, is that more and more contracting of primary care services is going to end up going through network contracts, which means it'll be harder and harder and harder for individual GPs to do things on their own. They will have to work together, and I think that's the direction that I certainly read into the national strategy. It's certainly what we would like to see happen, and we're already there and starting to see it. COVID's been terrible in many ways for local places, but it's also been very good for other things. So I remember sat here probably about 12 months ago, scratching my head with Nicola, trying to figure out how we get GPs to do online consultations. Well, we're sat here today, and every single practice now offers an online consultation. So it's amazing what a pandemic can do. Yeah, it's speeding things up.
Be forced to go down a certain route, haven't they?
Absolutely, and I think where we've been really successful over the past 6 or 7 months in particular is making sure that primary care is playing a very active part in the wider public service reform agenda. And I think we've real opportunities to start looking at our estate as one single public sector estate. The bit that galls me somewhat, and I appreciate we're live and in public, is all the PFI deals that the NHS has done over a number of years, requiring us to work in lift buildings. Actually, we should be able to consolidate some of that over a period of time with the local authority, looking very differently at one public sector estate as a place where we can create new health campuses that people come to get a variety of different services that are not just health, but are many different parts of the public service. I'm yet to find many people that live their life in just either a health lane or a benefits lane or a citizens advice lane. People generally work in communities and want to try and access a range of services according to their needs, and they have many different needs in different places, and those needs also differ according to other places. If I look at Saddleworth, I just find it a little bit odd that, first of all, we've got really rubbish primary care estates in Saddleworth. It's quite cramped, it's quite small, and everybody has to come down into Oldham to get the kind of specialist intensive type treatment. Well, moving us more towards this direction, I think, allows us to start saying, how do we get a little bit more sensitive towards service delivery in each of those neighbourhoods? It's going to take time, though, and want to manage your expectations. This will not be done overnight, but this is absolutely the starting gun for a new era of delivery going forward, and it's exciting as well as challenging.
Thank you for that, Mike. I mean, what I was thinking of was, in terms of some of our GP surgeries don't even have the basic accessibility needs there. So is there nothing that we can actually do on that? Some of them don't even meet the DDA compliance, to be honest with you. And at least there should be, I don't know if we can have some mystery shoppers going in, look, basically just checking upon the basics around DDA compliance. And that could be one of the routes that we could go down to make sure that certain sort of measures are carried out and the estate is improved, at least that way. And that could be like a stick for us as well to actually say.
I'll let Nicola answer that one.
Councillor Hamler, I've got you. You're next. So sorry about this.
No, it's okay, Chair. So I think we wouldn't say that we would use it as a stick. I think we're saying that we're going down the supportive measure of the quality assurance framework. Part of that is very much around the work that Mike and I have done with you all and with the whole system around actually people's concerns and issues. And this comes from primary care too, around how do we improve our own, because they are GPs first, businessmen second, and then trying to work being landlords. And I know that you can flip those either way. The point is that we're there now to support them with CQC, because that's the part that we are able to use from a contract lever perspective and actually start to work with the regulators. And it is interesting from a mystery shopper perspective, but actually if we're going in from a commissioner perspective with NHS England, with other peers, because it's very interesting when we do peer visits, when you've got somebody that delivers the same service as you going in to look around your building, it's amazing what can happen. So we're starting to do that, and actually we've really started to see some improvements by that. So that's how we're doing it. I think once we've got Q4 out of the way, we'll be able to then do a full review of actually how and what has improved. So we are doing that. It's with CQC. I recognise the DDA compliance is limited in some parts and in some practices, and they're the ones that very much are on our first list to go out and see. So we can come back and talk to you about that.
Okay, great. Thank you for that. Councillor Hamlet.
Thank you, Chair. Sorry, I was just putting to my mic command up. So, because there's a couple of, probably about 3 questions there. There's some bits in your report in the doc that sort of had a bit of, I suppose, some. I was trying to see in the demonstrating outcomes. There's just some bits there that clearly had some coding in there that I didn't quite understand, but I'm sure probably meant something to you, just lots of percentages, etc., and squiggly lines that just didn't make any sense to me whatsoever. Like, for instance, bullet point 3, number of 2 WWGP referrals restored at pre-COVID levels. But it's all right. I'll shotgun the rest of you to you. And then the rest, yeah, I noticed obviously you mentioned about some buildings' lives. For instance, I know one of our big things is about Chatterton, Crompton Health Surgery, and Saddleworth. Some of these are either prefabricated buildings which are currently being used, or are buildings that have been clearly hurriedly built, stuck together, and then they've just been left there to either leak or just slowly sort of rot away, and it's just not, they're no longer going to be fit for the next decade or the next 20 years or 25 years, etc. And I just think, you know, when it comes to actual folks who need that service, it's a bit poor, and it's a poor standard for what folk really need. And it's all well and good saying, well, you know, doctors can go digitally and probably do it from the consultation rooms or going on home, but you know, not everybody's going to be able to access that service. You know, especially in my patch, which we have a hell of a lot of elderly folk who live up in Crompton, but also those folks who are also, you know, who have SEND and AS needs. So I just don't know how you're going to get around that part very easily. And the last bit is, especially here in Shaw, we're heavily subscribed. I know, Councillor, I mean, you know, we have this thing about regarding chemists and pharmacies, etc. But we are so oversubscribed with a number of chemists, especially in Shaw and Crompton. But having one inside a building, you're just going to put another competitor, you know, another nearby pharmacy, their nose out of joint. And especially a lot of the time, it's not an independent pharmacy. It's one of the bigger national ones that gets in, you know, like Lloyd's or Co-op or also as well now, and they normally end up taking that space. So I don't particularly like this aspect of having a big supercentre with a chemist inside, because then you just put in the independent ones out of business. That's just my personal perspective on it.
So let me deal with a number of issues, Councillor Hamblett. So first of all, apologies for the acronyms. I know that will completely annoy Councillor McLaren. I'll get me lines later on this week and have to write them in front of him again. 2WW is 2 week wait. So basically, if you're suspected of cancer, you shouldn't wait longer than 2 weeks to get a diagnosis. So that's what that refers to. The squiggly lines are basically just shorthand for the word percentage. So the number of immunisations, the number of cycle screening. I think we've come a long way over the past 12 months, probably the last 24 months actually. We've got something in the region of 10,000 additional minutes available in primary care consultations now. We've got something like 5,000 patients that were invisible to us now visible to us because of the work we've been doing on prevalence identification. So really significant stuff. Buildings are a fascinating thing. I just think it's a complete and total shame that the NHS has found itself underdeveloped on its capital estate and infrastructure. You know, you only have to look at the Royal Oldham Hospital. That's not fit for purpose for the 21st century, and that's why there's a capital investment programme going on in the Oldham Hospital right now. Similarly, it is about primary care's revolution. We've been through the lift exercise, but what we need to get to, I think, is really looking at not just individual GP practices, but collections of practices offering multiple services to different people in communities from fit for purpose buildings, and that's the future. As for pharmacy, I'm definitely going to make a flag for you. Oldham's the only place in the whole of the country where there's more pharmacies than there are GP practices. So I'll just leave that there for you. We also spend more than anywhere else. In fact, we spend more on medication, drugs and medication than we do on doctors in primary care. This strategy is about starting to redress those balances, because that, frankly, is not acceptable in my opinion. We should be providing medications where people need them. I don't dispute that, but the cost of medication should not outweigh the cost of doctors. We should have plentiful supply of doctors within the realms of what's available, of course, nationally from training. But we have a very, very tailor-made regime of medication. However, I wouldn't want to leave you under any illusion that that's an easy thing to sort out, because I'm also more than acutely aware that there are people in our communities that can't afford a paracetamol over the counter at 30 and 40p because they've got other priorities, and that's a difficult that's a difficult thing. So it's very easy to give you some of the headlines. Some of the solutions that underlie that and are driving it are very real. I don't think there's any malpractice on people's behalf, but I think there is something that we have to do to redress the balances going forward, and this strategy is starting to move us in that direction, Councillor Hamblett.
Councillor Ibrahim.
Sorry, Chair, it was Councillor Brown before me.
Oh, sorry, Councillor Byrne.
Sorry, I was trying to unmute. I'm particularly interested in the restoration of patient participation groups. I didn't even realise they'd gone. I'm a bit before that. I used to be on Community Health Council, where we got some fabulous results. And I was thinking about that when you were talking about mystery shoppers. We didn't wrap ourselves up, we just went in and did it. I can see you nodding, Nicola. So I'm quite interested in that when you get to that stage, restoration of patient participation groups, because just referring to the, I shouldn't say over-prescription, but the use of prescriptions or people ordering things they don't need, I think that's the place where the patient participation could start.
I think there's a couple of comments, and I'll let Nicola come back specifically on the PPGs. I think it's got to be more than that as well, hasn't it? I think we've got to get to a place where we've got local representatives in community. So, without kind of trying to get too wide about this, we've just unveiled a national change programme in the NHS around integrating care, and my aspiration of that is that we end up in a place where we've got district boards in local authority language working with the primary care network directors and the local elected members all together to effect some of the change, and then PPGs working at practice level to try and put pressure on practices to make improvements. I'll let Nicola go further on PPGs, but I would like to see that kind of involvement as well, not just at practice level but at some of the policy setting areas in communities.
I do remember, and that's why I said mystery shopper or not, we need to go in, because part of that 10 years ago I was very much in that, and that's how we've based the quality assurance review. So we've worked with Health Watch, and we talked about it at Primary Care Commissioning Committee early in November, and we're going to meet Health Watch later next week to talk about this as well, around actually having them support us, so it isn't just a CCG thing, that this isn't just a commissioner going into practices. This very much has to be driven by the system and from a patient voice and from a citizen voice. So actually that we're working with Health Watch to get them involved to make sure that they can drive and work with practices to get effective PPGs, because often you only have it's the regular faces. It's about how do we get the voice of everybody, and how do we get the voice of the individual with a learning disability? How do we get the challenged and deprived young and people involved? How do we know what the voice is of how do we access, whether you're 101 or whether you're one, how do we get that right service? And that's around a real PPG, isn't it? Councillor Hamblett, in terms of what you've put into the chat, I'll drop you a line. It might be worthwhile us having a conversation, I think.
Councillor Ibrahim.
You're on mute, Councillor Ibrahim.
Sorry, keep forgetting to take it off mute. This type pandemic has obviously taught everyone, especially in the healthcare profession, quite a lot. Like Mike has mentioned, where we couldn't get doctors and GPs to have telephone consultations with patients, it's worked now because of the position that we're in. Through my profession, I feel that a lot of people are now self-medicating more. They're having to go to the doctors for basic things. And also, sometimes I feel some patients sometimes just want that reassurance that everything's okay. They just need to speak to a medical profession, and sometimes the GP they feel is the right person to give them that reassurance, and that's why they go to a GP and get that appointment, just to get that reassurance from that person that they feel comfortable giving that information to them. And Councillor Hamlett's point that he made before about these obviously Lloyd pharmacies and these main chain pharmacies getting pharmacies inside health centres, and I think they should go to tenders should go to local businesses or local people, because it's not fair. I mean, they do tend to get their pharmacies in health centres, and I mean at the moment that we've had so many patients walk into our pharmacies that have been let down by their delivery service, which they're getting I mean, a lot of the elderly patients in our areas and communities we've found have come to us because they've been told they've got to pay £90 a year for deliveries, or £70 a year for delivery service by Lloyd's Pharmacy. And you could imagine for people on basic benefits, that's ridiculous.
So I
it's
think
not fair.
It's completely not fair, and the look of horror on mine and Nicola's face.
Yeah.
So I think there's a couple of things in all of this. So first of all, we're not responsible for commissioning pharmacy, and I think we should be. So we are trying to influence that.
And I think we should be, especially now in your own, obviously, towns and cities. I think we should be.
I totally agree.
We are the people that give out the contracts, aren't we, at the end of the day? So
not for them, unfortunately.
Are we not? All right, okay.
No, it's great.
We offer local independence.
Are we not responsible for the contracts given out in the lift buildings? No.
Not for pharmacy, no.
Only
GP practices. So pharmacy, I totally agree with. That's horrifying. And I think we could probably do with a conversation outside of here about some of the stories that get played.
And then the other point that you made, Mike, about Oldham having more pharmacies than actually GP surgeries. And I think the point that Councillor Ibrahim has just made, that might be one of the reasons, because if the big boys are coming in, taking some of these bigger contracts, and some of the local sort of pharmacies, businesses have no other option but to open up elsewhere. And I know in the past, I sort of represented one of these local pharmacies where the larger chains got together to stop this pharmacy being opened up in Oldham, because they all sort of, I don't want to like ganged up on them, this local pharmacy, to say, no, there's no need for it. And that was really disturbing for me to see that at the time, thinking, hold on, this is the kind of sort of culture that goes on, because they all came together to say, look, this pharmacy is not needed, and it's quite obvious in that particular area at the time it was needed.
There's quite a long story, I think, around why we've got to the place we have. But you know, when was the last time this committee looked at a pharmacy needs assessment, for example?
Yeah.
You know, so there are things here that we need to start getting in place. In response to Councillor Ibrahim, some of Councillor Ibrahim's specific points, health literacy in Oldham is really, really poor. You know, I also live in a very deprived area of the country, which is not in Oldham, and health literacy is considerably better. I think we need to do an awful lot more about educating our population about what is good, what is not acceptable, what to expect, what not to expect. And we are never going to do that with the best will in the world with an individual like me who doesn't understand all of the communities. We need the communities to work with us to help their own communities. Yeah. And that's the type of program. So, you know, back to Councillor Byrne's point about PPGs, I tend to find that most PPGs are, with the best will in the world, they look a bit like Councillor McLaren and want to get involved in these things. What we need is a much more diverse approach to PPGs that are fully representative of the patient list and are there to help and support. We have very much a system in Oldham where too much access is directly to the GP, and a lot of that is driven by culture, and I don't necessarily disagree with some of it, but we run out of capacity very, very quickly when we operate in that way, and there's different things that we can do nowadays. So I think, you know, as I say, this is the start of a really exciting period of time. I definitely think this committee ought to be challenging itself about how it can get more involved and what it expects of us. I would like to think this is just a framing conversation for what comes after it, but there are some big things that we've already sorted out, like the 5,000 additional patients that are now on our prevalence registers, that we can see, you know, these people were just going unhelped, unknown, unrecognised, and their only way of dealing with care was to directly walk into A&E every single time they were unwell, which costs us an absolute fortune. And that's not to say I'm overly bothered about money, but if we're investing everything in A&E services, we can't be investing in primary care services. We need to tip the balance back, and money needs to be in communities near where people live and work.
I think two of our future what we can do in the work programme is obviously looking at the pharmacy strategy, but at the same time, if we can have the prescription sort of strategy, or in terms of how we can reduce that budget, if you can bring a report back to the committee, that would be quite useful as well, in terms of educating the population around if we reduce that budget, how we can spend that money on something else to improve our population's health.
We would love to. I'm sure Nicola will kind of attest, as I will. You know, my view is we spend £8 million more on prescriptions than Berry. What's that about?
And what that 8 million could be used elsewhere for.
It's a big number.
Hello? I just lost you for a minute. It all froze.
Are we back?
I'm back, yeah.
So, you know, there are very much things that we can bring back to this committee over the course of the next 12 months. Absolutely. Yep.
Councillor McLaren, Councillor Burton, have you got your hand up again?
Hi, thank you, Chair. Much of this conversation that we've had over the last quarter of an hour or so focuses on one word: prevention. Actually, and this has been a major theme of all of the proposed reforms, restructuring that we've been discussing, if you like, over the last 3 or 4 or 5 years even. So I'm just wondering, I mean, clearly there is the beginnings of a strategy that's emerging from this conversation, but in terms of actual prevention, what steps are we taking to be, if you like, more focused in that kind of approach? This sort of goes around the theme of more with less, if you like, and trying to front load the budget so that we prevent rather than have to cure. And this has been at the forefront of many of the discussions at Greater Manchester and elsewhere over the past 3-4 years, as it were. So what steps are we actually taking to promote that approach?
So that's an interesting question, isn't it? This is the start. So where are we in putting that across? I think it's the work that we're doing with Mark Warren. It's the work that we're doing with the system and around the integration. The whole preventative work is around what we're trying to do with redirecting workforce. It's redirecting the money, it's redirecting where we are, and like Mike started the conversation, none of this was in place. This is now where we're starting to get the strategies for each of the areas, for each of the work streams. And I think that the big part is for us is getting, so the average reading age in Oldham is 4 and below, and you know, how do we do that? We need to get PPGs, we need to work closer with yourselves to understand what it is and which area, which ward across Oldham, what do they need, because this isn't a one size fits all for Oldham, is it? This is very much around understanding what each of your wards needs for us to be able to make sure that the PCNs, that the community health teams, that the A&E is all saying the same things, but reaching out to make sure everybody understands. So I don't know, but I think this is the start of how we can start that preventative work.
So the one thing I'd just add really is that we spent a while developing a model of care for Oldham. That's well and truly there now. We're now starting to bring together all the different strands of that. So thriving communities, focused care workers, the Right Start work, all of these things need to come into one single space and be understood as one single part of a system, instead of many organisations focusing on different small parts of the preventative agenda. And then fundamentally, Councillor McCarran, we've got to stop making sure everything that is an acute episode, we need to start shifting some of those episodes into different settings. And, you know, as we bring stuff out of hospital into primary care, we need to move stuff out of primary care into prevention and start to take demand out. And to do that, we need a more asset-based community development type model, a strengths-based model, call it whatever you want. It's all the same kind of ideology.
Well, I think, as you said, there's a conversation to be had around this subject, which obviously we could bring back to a future meeting, but I think we need to do some prep work beforehand, as it were. And I'm quite happy to, I'm sure the chair is also, to engage with that kind of approach and perhaps have a look at the programme in terms of what might be brought back, as it were, over the next, if you like, range of meetings, workshops and other strategies that we might be able to promote. Yeah,
definitely. Just a couple of more things that I wanted to add. I mean, in terms of PCN itself, when are we going to get them sort of actually set up? And I know they're set up, but in terms of accountability, member representation, etc. Because we've been waiting for that for a couple of years now, I think. And
all of that's in place. All of it's in place. There's nothing that's not in place with PCNs now at all.
As members, local members, we don't get invited to them.
So I think we're talking about two different things here. So primary care networks are groups of GP practices with governance frameworks around them. What we've set out in a roadmap for the future is how do we connect them into the neighbourhood boards?
Yeah.
And that's set out to start to be designed next year.
Right, okay. Well, that's fine. And then one last point for myself is, obviously around the lift contracts that we've got around PFI, etc. I know in other sectors, those sectors have started to renegotiate those PFI contracts because obviously they were costing them a lot of money. And have we started to do that within the health sector as well? Or
yeah, we have. And I think there's probably a bigger conversation about if we treat it as one public estate. I think there's an opportunity for the council to buy out some of those lift contracts and create a revenue stream for itself as part of it. But that's part of a much more strategic conversation going on elsewhere around the Creating a Better Place programme. So I don't think one single model or modus operandi is the way forward. I think we've got multiple strands that we can start to think about now.
Right, okay. Is there anything else from any of the members? Any more questions or comments?
Just a question of how we follow this up, Chair. I think that's the main issue.
I wonder if there's a suggestion, Chair, whether it's worth yourself, myself, Mark, Nicola, maybe Councillor McLaren or any other member just having a focused hours conversation about some of the planning. I don't think it needs to be limited to just two of you. We're quite happy to meet all.
Anybody else who wants to be involved, we can have a meeting outside this committee.
Yeah, I think so.
Bring the report back. So I'll ask Mark to arrange that, and then we bring it back into one of the future meetings. So that's one recommendation, Mark, there. So to set up a subgroup to look at how we're going to take this forward. Other than that, the report is noted, and I would like to thank Mike and Nicola for their presentation this evening, and thank you for your time.
Thank you.
Okay, thank you very much.
Thanks.
Take care. Thank you.
Take it easy. Have a good evening.
Thank you. All the best.
Bye.
Bye.
Moving on to item 10. The next report is an update on the local implementation of the Greater Manchester Learning Disability. To present the report this evening, we have Charlotte Walker. Is Charlotte with us from the Council's Community Health and Adult Social Care Service, and Gary Flanagan from the CCG. I don't think is Gary with us. I don't think Gary's here.
Apologies, Chair. We've had to have a slight change of plan as to who's attending, owing to what can best be described as a somewhat disastrous IT scenario for Gary today.
Right, okay.
Your worst case scenario of an IT. So Joe Charlin, our commissioning manager for learning disabilities, has kindly joined us. Joe actually wrote most of the report that we're presenting, so it seems fair that he's here as well on Gary's behalf.
Right, okay, that's fine. So Joe and Charlotte, could you please present the report to us and introduce yourself to us as well?
Yes, so good evening, everybody. For those that don't know me, my name's Charlotte Walker. I'm the Head of Service for the Integrated Adults Learning Disability and Autism Service here in Oldham. Joe?
I'm Commissioning Manager for Learning Disability and Autism here in Oldham.
So it's thank you for welcoming us today, and thank you for inviting us to attend. So Joe has summarised in the report that's within the papers an update on the position in Oldham with regards to our learning disability and autism strategies. You will note from the papers that there is a code with regards to an asterisk on certain of the work streams where there is a direct crossover between the learning disability strategy and the autism strategies. They are two separate and quite distinct strategies in Oldham and in GM. But obviously there is crossover in certain areas, especially when it comes to some of our commissioned services and how we support adults with learning disabilities and or autism in Oldham. So we thought we would take you through on a bit of a whistle stop, but I will try not to rush. I do speak quite quickly, so by all means, let me know. But to take us back a little step, the Greater Manchester Learning Disability Strategy was introduced probably, must be coming up to nearly 2 years or slightly more by now. The COVID impact of time is somewhat confusing at points, but going back about 18 months, 2 years ago, Greater Manchester launched a learning disability strategy. And in Oldham, we've been embedding it during that time alongside the autism strategies. In summary, the briefing that you'll see within the paper sets out some of the challenges and successes we've faced in implementing the strategy, but also the context of COVID-19 and how that has influenced how we've worked in the last, 10 months or so. In summary, the high level kind of points are that work continues in undertaking a review of accommodation for people with learning disabilities, and Joe will talk a little bit more about that when we get to it. That we're implementing alternative methods of working to support people, for example, creative models of delivery around day services. That work has been able to continue, albeit with a COVID lens, and in particular there have been some real successes in the health theme, especially in supporting annual health checks, and that many of the individuals with learning disabilities and autism have found the disruption difficult to deal with. But it's important to note that there's been really good resilience within the cohort of people coping with the help of the support that they're receiving, but also with the actual provider market itself, people that are delivering the hands-on support and care. The resilience there has been exceptional. So, as I said, the strategy has been in place now for over a year, coming up to 2. In the design of the strategy, there are 10 themes as set out in section 2 of the paper, but across GM, we've collectively been reviewing how COVID itself has almost become its own work stream, and we are considering certain areas that don't cross into the other work stream. So to list them, and we actually spent half the day today updating where we're at. So strategic leadership, advocacy, belonging, bespoke commissioning, good health, homes for people, employment, workforce, early support for children and young people, criminal justice, and then, as I say, COVID comes in as an 11th work stream. The double asterisk makes reference to that crossover with the autism strategies as well. So in summary, for each of the strategy themes, within the strategic leadership, we link very closely with our Learning Disability Partnership Board and equally the Autism Way Forward Partnership Board in ensuring that we're linking across what's being discussed and embedded and delivered in GM, how is that feeding through into Oldham, into the Partnership Board, and then vice versa. We work very closely with the Carers Partnership Board as well. And the LD strategy forms part of our integrated team business plan. An audit was completed, probably started this time last year now, by Council and Pennine Care auditors, and it's important to note that the service itself is a combination of Oldham Council adult social care staff and Pennine Care NHS allied health practitioners. We have a series of different disciplines represented in the service. We have a nominated and named lead to coordinate the implementation of the plan, and Mark Warren as our DAS very much leads on the overall strategy of learning disabilities in Oldham, but also from a Greater Manchester and now a North West perspective. So we have that real connection with Mark in that role. We've worked very closely with colleagues across GM and the North West, supporting individuals, their families and carers throughout COVID. And what I've been very pleased to see and assured to see that it's been slightly differently reflected in other areas is how adults with learning disabilities and autism have featured very much in our plans around support and in the COVID response itself, making sure that we're thinking about that cohort of people alongside some of our adults in care homes, for example. There's been a real focus on that partnership working, which has really strengthened. We've managed to maintain the partnership board meetings themselves virtually. We are working on finding ways of a blended version, so that we've ideally, with due risk assessment and social distancing in place, have an opportunity to enable us to have people dialing in, but also a small group of distanced people, ideally to physically be in a space. One of the things that we've had fed back, which is completely understandable, is that parents and carers especially, and some of our individuals, are missing the access to those meetings. From an advocacy and belonging perspective, we've been working with various providers, namely MyoCare, Keyring, Future Directions and Opal. Prior to COVID, a speakeasy was held in October with a real focus on employment, and Get Oldham Working were present. So Opal facilitated the speakeasy, and that was a monthly event until COVID happened. We're working with Stockport Advocacy around learning from their services and developing the Learn Disability Friend initiatives. But part of the challenge has been that Opal itself were furloughed for at least 3 months at the start of COVID. They are back up and running in a version, but that has been a particular challenge. That said, Opal do support us in the background with a lot of easy read versions of information. They link with social media. And Camilla from Opal is very closely involved in our work. At that point, I will pass to Joe to talk us through bespoke commissioning and accommodation, if you can, Joe.
Thank you. Okay, so bespoke commissioning. We've been delayed, I would say, significantly on some of this, partly because of COVID, but in a positive light, that has allowed us to look at things differently, and has probably thrown up things that we weren't aware of. So, for example, some of our work around daycare, or day services rather, is that's supporting that work. In terms of some of the stuff to do with EPAC, that is the extending and embedding a personalised preventative approach to commissioning, which is a bit of a mouthful, but that's where that day service focus has ended up going, and supporting people to get back into day services very safely. But what it's done is allowed us to view that and think, well, how can we support day services to run better, and how can we ensure that there's value for money for those clients who are day service customers, and also achieve good outcomes as a result of going there. So I think that's the summary of that. I can talk a bit about the accommodation one. Is that all right, Charlotte?
Yeah, by all means.
To the housing section. Sorry, I am jumping on a little bit, but the two are very connected. So in terms of homes for people, the supported living framework that we've currently got for people with learning disabilities and/or autism is probably 3 or 4 years into its run now, and as part of the work that we're doing over kind of achieving better outcomes, we're doing an accommodation review. So in terms of the homes for people, what we're doing at the moment is a desktop review of who's living in particular houses, what are their needs, how are their packages of care set up, how could they be changed to become more efficient, and where do people have choice to a large extent? What are they able to choose insofar as the care and the type of home that they live in? So some of that work has begun a little bit later, admittedly, but that's underway, and we're looking at things like the data, groups of cohorts of people that live in houses, particularly say single occupancy houses, and looking at if they're efficient enough, and it's considering about reasonable cost, and the processes for people to access supported housing, particularly if they've got a mild to moderate learning disability or difficulty, and a review of our housing capacity, because we know that we've got some capacity, but it isn't always fit for purpose. It's not always the people that we've got on housing list are compatible with the vacancies that we've got. And just the last bit, and then I'll stop talking, is that it ought to be I think it was it Limehouse? Forgive me if I'm wrong on that one. Which is in Limeside, and we've got 6 people living in there so far. So we're currently on a matching process to get more people living there.
Yeah, I don't know if others found Joe's connection. I don't know if it was just mine, but Joe's connection went ever so slightly. It was quite a surreal moment where Joe slowed down and then sped up. And that final bit with regards to the property on Limeside is Hollybank. So I think we have talked about it previously, but Hollybank is a bespoke designed, purpose-built I was going to use the word facility, but it feels clinical, but residence, basically, set of flats where there are 20 flats. We currently have approximately 6 people moving in. They've been living there for a number of months. Even with lockdown restrictions, we've managed to balance some of that as we've supported people to move in, and it's an ongoing process. It is taking longer than we probably would have hoped because of COVID and the impact that has on being able to get out and do assessments and support people in that transition planning. But that is very much a live set of flats that we're working with MyoCare around running. So that's a real success story. It's just taking longer than we thought at this point. If I go back to one of the key things I really wanted to talk about is health. Because there's quite a lot in the paper, but obviously in the world of COVID and the impact of COVID itself on people's health, it reflects something that Mike was referring to around some of the positives within the COVID experience. And some of the things that we found is how we're really beginning to understand how we communicate. We're working at a pace, we're working in ways we've never been able to work before because of organisational boundaries, and IT itself, meetings like this being able to happen and consultations with practitioners and professionals is absolutely key. So the good health work stream of the overarching strategies has made a lot of progress, and then and some of that has been at real pace because of COVID. So there's more breakdown within it to give some of that detail. So there was some information to cross-reference registers. So whether that's within the health element of the team, so adult social care, GPs, acute, there was a lot of work done to cross-reference to understand that we have a clear list of people, adults with learning disabilities and/or autism, and that's part of understanding who might need reasonable adjustments, who might need particular support to access appointments, who might benefit from a hospital passport, those types of layers of work that supports people. We work very closely with the hospital lead nurse, Ruth Bell, and a pharmacist has worked with 4 of our GP practices around a real focus on patients who are prescribed antipsychotic medication around the STOMP agenda. So that's the stopping of the over-medication of adults with learning disabilities. From a shielding perspective, early in lockdown, it was identified that there was a bit of confusion around shielding adults with learning disabilities. So Gary Flanagan as our lead commissioner and other people involved in the wider world of primary care and learning disabilities worked together to develop a protocol for our Oldham GPs that captured the highest risk people with learning disabilities and or autism, risk being around the needing to shield, so talking about that clinically extremely vulnerable and the comorbidities that might then place you at greater risk if you were to contract COVID, and then an at-risk vulnerable people with learning disability and or autism who need additional support. So all practices within Oldham CCG received that guidance as early as the 27th of March, and we've been working with them ongoing to develop that and to really understand who was most at risk. Our annual health checks, currently we're achieving 57% against a national target of 75. COVID has had an impact on that, but we've been working with practices and linking together with primary care commissioners especially around how we get to underneath it to really understand particular practices if their performance is particularly poor on this type of return. Is it that they are undertaking the annual health checks but they're not completing it in the right way on the system that then leads to the reporting back to CCG? is it that actually some work is needed with the practice around understanding what reasonable adjustments people might need? And that's an ongoing piece of work at the moment. Part of that is we've also then been successful in a bid to NHS England, I think it was, for funding around an annual health check exemplar. So our proposal, which has been supported, is to develop an outreach learning disability registered nurse who will work alongside the practices to ensure the registers are up to date, reasonable adjustments are recorded, but also making sure that they're actually filling in the relevant aspect of a data return, whilst also understanding what it means to undertake an annual health check for somebody, especially in a world where some of it has to be done virtually maybe. They will be complementing the work of the LD link nurses in the service, because each of the learning disability nurses in our service are linked to the PCNs. But what we're hoping is we will, using the data that we now have access to, we'll be able to focus in on particular practices in a more intense piece of work to improve that performance. That is out, I think that will be, the job role itself has been approved, and I think they were hoping that they'll be in post as early as January. Testing from a COVID perspective, we have a specific LD testing plan, which has cohorted the people that we're working with so that we can really focus in again. So it's things like testing for people living alone, testing for people living with family with low needs but not accessing services, but they're registered with an LD with the GP, right up to some of our people with the most complex needs, either living at home or in supported living. And in the background with people with the complex needs especially are risk assessments and a protocol around if you needed to do a COVID swab for somebody who's maybe communication needs, they're not going to understand what you're asking them to do. They may not tolerate the swab itself. I don't know if you've had a COVID swab, but you really need to appreciate that it's not going to be fun necessarily, because the swabbing process itself is quite invasive, especially for somebody that doesn't understand why you're doing it and what it's for. So there's appropriate risk assessments and support management around that, very much working with providers and focusing on that person's needs themselves. Sorry, my computer stopped responding. Bear with me one sec. You'll also see in the paper a focus on the learning disability mortality reviews. This is an annual report, and we've recently in Oldham had our LEDA report that's been submitted to CCG and has been brought to LD Partnership Board certainly last week. There are themes nationally with the LD mortality reviews, especially with the lens around COVID when it's respiratory conditions. There was significant concerns from the initial rapid reviews that happened around silent hypoxia. So somebody being short of oxygen, but with none of the usual visual signs or coughing or those types of changes that you'd expect. In some instances, people had gone to bed appearing fine and died in the night. So we're working very closely with Janine Campbell, who's the safeguarding nurse for the CCG, and colleagues in the health aspect of the team to embed an action plan specifically around LEDA reviews. As I've said, a lot of that is national, but in Oldham we're really focusing in on what do we need to do in our service area. And there are specific KPIs linked to LEDA reviews for the CCG, which I'll let you read in the paper. I'm conscious of time, so if I will just couple of other quick points, and then I'll take questions. So within the paper as well, we talk about employment and workforce. Employment focus is around how we support adults with learning disability and or autism into the workplace. So whether that's accessing apprenticeships or supported employment services, or whether that's as an organisation and an employer ourselves, that we look at what reasonable adjustments we might need to make, or what adjustments full stop we might need to make to our recruitment processes, our reliance on online, for example, what adjustments you might need to make in an interview, but also how you work with adults with learning disabilities and or autism to support them to stay in the workplace, and what help do they need, or rather not even help, what understanding do they need from their colleagues and their managers. And specific updates around the Pure Innovation Supported Employment Service. That was postponed because of COVID, but it started early August. We've seen, I don't know the actual number because it changes week on week, but constant referrals through to that service. And last time I checked, we've already seen somebody go into a successful job placement. Also, the Making Every Adult Matter programme has seen 10 people with disabilities funded into employment. From a workforce perspective, so that's our actual workforce within my service area, so the health and social care team, but then that does broaden out into provider, especially from a myocare perspective. It's a real focus on training. So we talked last week at the Autism Way Forward Partnership Board around autism training. We're developing a plan and developing a suite almost of training packages. So there'll be an initial autism awareness e-learning package within the council's website, but then we're in the final stages of developing a specific bespoke training package for social care practitioners, which will be presented in line with the national framework, but then also other health and social care practitioners and involved people, which ideally will span out into other sectors like housing and justice. We've had bespoke training in Mental Capacity Act and Court of Protection, and we're working through the internal aspects of process, policies and procedures on the basis of us having two organisations working together in one team. And finally, to talk about early support for children and young people and transitions, it is an area of the strategy that has taken longer to get off the ground, somewhat challenged in having people who can drive the link, who can create the links across adults and children's, but we are now working very closely with the newly appointed SEND AD, David Shaw, and our Head of Service for Children with Disabilities, Richard Smaling, working very closely with both of them in their service areas to bring it all together. And that includes this week, we're undertaking a rapid improvement session on Thursday, I think it is, where I'm meeting with key managers in my service area and equivalents in children's services to start a rapid process around what we need to do for young people transitioning from 14 upwards through to 18 and then beyond. At the moment, it is somewhat disjointed. So we're working very closely, and that links through to the Adult Safeguarding Board and the Children's Safeguarding Board for governance and assurance. So there is a real drive around transitions. Joe, have I missed anything from your perspective?
No.
I'm very conscious I've just spoken at the screen, and the joy of presenting on Teams is you can't see yourself because you've got the thing on screen, and I'm a big believer in reading non-verbals. So I'm happy to take questions.
Are there any questions from members?
Councillor Byrne has a hand up, and Councillor McLaren.
Chair.
Yeah, Councillor McLaren, go ahead.
Yeah, okay, thank you, Chair. Well, hello, Joe. Long time no speak, as they say. But you did touch on one of my two questions I was going to ask, actually, on accommodation. And you say you're carrying out what you might call a desktop review. Are you able to give us any indication as to what is emerging from this review at this point, and whether we have sufficient places available, or whether we need to expand the capacity in some shape or form in the short, medium term?
I've not got any results of the review, but what I've got is some sort of key lines of inquiry that are forming the basis of what to look at in terms of that review. So, for example, places with single occupancy, because they tend to be more expensive, and it's whether people, whether they've been there a long time and it's time to look at whether they could move, or whether it's fine for them to stay where they are, or there could be other opportunities for them. We know we've got an ageing population of people with learning disabilities, and some of those are going into different forms of care. There's also, we've got one of our providers who's agreed to be a pilot because they've come up with some ideas of how things could be done more efficiently. So everybody's got a care plan, but the providers know best how to look after that person and work with them. So they've come to us with some ideas. So we're going to use them as an example of just have a look at how those houses are set up, who's in there, what are the costs of the packages, what are the outcomes in particular for those individuals. So those are some of the things that have come up as we've been working over probably the last year, 18 months. And we've got, actually, we'll look at those things first before we look at anything else. Does that answer your question?
It's a step in the right direction, Joe, but obviously I think we'd be interested in the outcome as well at some point. Yeah.
Yeah.
All right.
Me too.
My question for you, sorry, Joe. My question for you, Charlotte, is about education, training, and employment.
Mm-hmm.
Now you've touched upon it, but you've not actually sort of suggested how that program is actually developed.
Very good point. I kind of sped past that bit at the end. I think it has been challenging as we've gone along, pulling information together to really understand who of the people that we work with, what's our employment offer, especially around adults that we work with that are known to services, who's in employment, who's in training. The data collection has been somewhat challenging, to say the least. That said, we undertook a big piece of work immediately prior to COVID to capture and pull together the information about all of the different supported employment schemes, right from kind of that college age, 16, 17, whether that's apprenticeships, internships, work placement, but also some of the funded schemes that are now in place because of COVID. There's been quite a spike in digital offers. So that's where the links with SEND especially are coming in, so that we're making sure that as people are coming through from education, that we're planning that ahead and that we're looking at what young people want to do. And I think one of the things that where Joe was talking earlier about thinking differently about day services, has included colleges, has included young people staying in education, and then actually COVID's kind of forced our hand in many ways. And what we're seeing with a lot of young people is they don't want to be in school, in inverted commas, they don't want to be in college or education, they want a job. They want some normality that isn't a version of continuing in education. So I work quite closely with Donna Lewis in inclusion, and we're trying to bring it all together as part of that work around transitions itself as well. It is early days. I think that's my note of caution. It is early days, but what I have seen is a shift in my own service area because we've got the information all together. It's on a spreadsheet at the moment. I want to make it more interactive and more accessible. But because we've got that information together, they're clearer on, well, if I'm working with a young person and their interest is in web design, using an example, what are the different options of supported employment services or a training course they could go on, and how do I refer? But importantly, we've also captured how are the schemes funded, because a lot of them obviously come from different pockets of grants and stuff like that. So it's making sure that we've got that information. It is early days. I'm happy to come back in the future at a future date with a further update, just in general on the strategy or things in particular. That's absolutely fine.
Thank you.
Councillor Byrne has a hand up, Chair.
Thank you.
Sorry, I was on silent. Yeah, Councillor Byrne and then Councillor Alias.
Yeah. How many care leavers with problems like autism or other disabilities do you cross over with? And certainly in terms of what Joe was saying about accommodation, does that ever cross over or not?
They absolutely cross over.
Yeah.
I can't quantify it at this moment in time. as in, I don't know the number off the top of my head.
Yeah.
What I would say is it's a significant piece of activity within my service area. We have dedicated social workers, especially linked to that. The demand is quite high on that bit of the service at the moment, but that's part of the work that we're doing with Richard Smaling and his team, is to understand at what point do we need to get involved as adult services. At the moment, it's quite an informal process, usually on a case-by-case basis, usually on a level of complexity and risk. The sooner we get involved, the better for me. We've got to balance that capacity and demand in the service. And there's aspects of support and work alongside children's social workers and health practitioners that we're doing. But we've got to be really clear on roles and responsibilities, because sometimes you end up in a situation of too many cooks and nothing actually gets achieved. Yeah. But I think it's fair to say that it is quite a demand on the service, and it's something that we're really trying to understand and get underneath so that we are able to quantify it, but also then plan ahead, because at the moment we know we've got people coming through to 18, people turning 18 every day, but it's a bit of a challenge at the moment to be able to think 6 months, 12 months, 2 years in advance of what that could look like, and how it then links back to accommodation and care services. So the way we're doing it, Joe's very much embedded in those conversations, or will be, so that we can make sure that if we're planning, Joe and I have had a conversation, if we're planning to reconsider and redesign how a particular service that we commission is used, would it be relevant and appropriate to think about having something dedicated for younger people preparing for adulthood, so that they can try and they can maybe live in an environment that they wouldn't necessarily have thought of, but with a practice around it. And I will stop talking in a sec, but that's including consideration of actually, with some settings and some registered care providers, for example, if we were to approach CQC and Ofsted around changing the registration from 18 and above to 16 and above, could we have a bit of an interim service? And that would have a massive impact on some of our younger people.
Yeah,
so it's definitely there.
Thank you.
Councillor Alias.
Thank you, Chair, and thanks for the presentation. There's quite a lot of information both in the reports and in the presentation. I've got 3 small questions. So first one is around the day services. I know we've not been able to provide day services throughout the COVID period in the main, and just wanted to know if there was anything that we have been doing in terms of maybe providing some support over telephone to some of these people, or have we been doing anything at all? And secondly, I know a lot of adults with learning disabilities that come within the Pakistani or Asian community in particular, they tend to be cared for within the family setting. And what support is available for their carers? Because from some of the ones that I know, their carers tend to be ladies, their mother or somebody in the family who don't really speak much English or understand, and they can't. They don't have a lot of access or knowledge to IT stuff. So if you could just elaborate a little bit on what support is available for the carers in particular in that case. And thirdly, I know you touched a little bit on this question on Hollybank. Do we have any employees from within the Asian or BME communities who might help encourage some of these people with learning disabilities from the Asian and BME communities to come and live in this particular facility, or what you want to call it? And just finally, have we got any training programs that we provide to encourage people to work within the learning and disability sort of sector? Thank you.
Okay. So
a number of questions there for you.
I know there was definitely 4. So if I go backwards, the last question was around training and to encourage people to work with adults with learning disabilities. I think there are definitely under skills for care. Usually, the specific focus on. So Skills for Care is a national training body, but they usually run the training courses for access for people working in social care, and usually kind of that care delivery, so working in care homes and working for care providers. I'm not sure whether it's specifically around learning disabilities, but I would expect it to be. I can certainly take that as a question and gather more information. Certainly MyoCare as one of our lead providers in Oldham do publicise quite actively, I think, about coming and working with adults with learning disabilities. There was a question around support for parents and carers, especially from BME communities, wasn't there? So I think on a case-by-case basis specifically, we work very closely with parents and carers. And we would routinely work with people around them accessing carers assessments in their own right and understanding what other support the family as a whole would benefit from. I think it's probably an area of real focus, and certainly I discussed with one of our colleagues this morning in the CCG around CCG have a BME link worker who has been fundamental in the delivery of the dementia strategy and the design of the dementia strategy. And Cliff and I had talked before about using him to support, seeing how we could use the worker to link through to learning disabilities and autism. So I'll pick that back up with Cliff, because I think you're right, it's an absolutely key part of the process. Hollybank, off the top of my head, I don't know if there are staff from BME and Asian backgrounds working at Hollybank itself. There are certainly a number of support workers who work for MyoCare from the local community, and I can think of a couple of bespoke packages especially who we have a number of male support workers from Asian backgrounds working with a particular gentleman, but I'm happy to link with Diane Taylor at MyoCare to give you more detail on that, because it's a key point around building that connectivity, isn't it? What was the other question? It was day services, wasn't it? And alternatives. Joe, can you give more detail on that?
Yeah, just to give you a quick background, we don't commission formally anything in terms of day services for people with learning disabilities. We only commission a couple of dementia day services. So just to be clear on what we've got control of and what we don't. So in terms of day services for people with learning disabilities, individuals get a personal budget and they do with that whatever they want, and if they go to a day service, that's totally up to them. We don't have any contractual obligations with them. They are micro commissioners, if you like. And so when we were in the position that we're in, we had to ask the day services that we were aware of to close for the safety of the individuals. We were in lockdown, that happened. Then when we came out of lockdown, we were asked what can we do? So it was like, well, we know that a lot of people are really struggling. Parents, carers are struggling. They need respite. Individuals are fed up of sitting at home, as we all are. So what we've done is work with day services to try and support them to deliver in different ways. So we've got some that are doing online work with the people that they work with. Opal, I know, are delivering day services, so they'll have a big screen. Some people are at home. They are using Teams as we are. They come up on a big TV. The people within the day service are socially distancing, taking careful precautions, and they're kind of doing it in a kind of mixed way. Some services are doing them outside. Some services are sending activity packs out. They're doing calls, Zoom calls with people to make sure that they're okay. People have been supported to access PAs rather than go to day services if they really need to get out. So there's different things that people have been able to do to access something, even if it isn't exactly what they had before. Does that answer your question sufficiently, Councillor? You're on mute.
Councillor Alias. Are you happy with that answer, Councillor Alias?
I think that answers my questions. Whether I'm happy with it, that's a different story.
Right, okay. Are there any further questions or comments from any members? No. Charlotte and Joe, thank you very much for that comprehensive report. More than happy for you to stay with us for the rest of the meeting if you want to, but I'm sure you've got plenty of better things to do.
I've certainly got square eyes from looking at it all day, so thank you. But I think for one, I'll leave you to it. Just to say, I'll happily come back again at a later date. I'll link with Joe and I'll link with Mark Warren around kind of when that is, because it's how we bring it all together. But yeah, it was really nice to see you all. Thank you for listening to us.
All the best for Christmas and the New Year.
Thank you. Thank you.
Thank you.
Bye.
All the best.
Right, moving on. Sorry, I forgot to ask you whether your members are happy to note that report or not. I'm assuming you are.
Happy to note, Chair, but perhaps we could bring him back in 12 months.
Yeah, that's fine. Yeah, we'll do that. We'll put it on the work programme. So we'll move on to item 11, which is it's the further consideration of the proposed amendment to the council motion related to United Nations Sustainable Development Goals report to council. We have a report in front of us. Mark, do you want to add anything to the report?
Yeah, I think the only thing I would add, you did ask that the other political groups on the council be asked whether they had anything to add in terms of names to the list of bodies in the amendment. I have written to Conservative and Labour group leaders and secretaries as appropriate, and I've not had a response back. So the consideration of that amendment is back over to the committee chair.
Councillor McLaren.
Well, just to add to what Mark said, Chair, that Overview and Scrutiny recommended that it should not be added to the report that was approved by Council, given that the political group concerned had 12 months in which to refer the item to the task and finish group that was considering the matter.
So are you moving that we shouldn't add it to the report then?
Move that we shouldn't add it to the report, Chair.
Right, okay. Is there a seconder to that? Councillor Alias?
Yeah, I'll second it.
Okay. Right. Is there any further comments from anyone? No? Right, okay.
Chair, we will need to take a vote on that because that will end up back at council. So the proposal is to not agree. Is to not agree the inclusion of the amendment in the original report. So, Councillor Alias. This is the vote on whether to not agree the amendment.
So, sorry, Chair, just to be clear, if we vote for, we're voting for the inclusion of the report. If we're voting against, we're voting against the inclusion of the report in the.
If you vote for, you are voting against the inclusion of the amendment.
Right, so that's what we just needed to check out.
Are you just confusing us, Mark?
Councillor Alias.
Yeah, I'm voting against the inclusion of the report.
Right. So you're voting for, right?
For.
Councillor Byrne.
Don't think she's with us.
No, I think she's gone. Councillor Hamblett has gone. Councillor Ibrahim.
4.
Councillor McLaren.
4.
And Councillor Akhtar.
4.
4. Right. Thank you,
the
Chair. So the amendment is not included in the report. And
could you please, Mark, could you note that the other members weren't present?
Right.
where the vote took place.
Yeah, because they have actually left now.
So the amendment is carried then.
So you have agreed not to include the amendment to the report.
Yeah.
Yeah. Okay.
Okay, then we'll move on. Item 12 is our initial consideration of the council motion. Not every disability is visible. And joining us this evening is Sarah. Is it Sarah or Sarah Hollowborn, campaigns manager from Crohn's and Colitis UK. However, first we have a report before us. Mark, could you introduce the report, please, before we bring Sarah in?
Yeah, thank you, Chair. The report presents details of the motion as submitted to Council. I just thought it would be helpful for your initial consideration, just to put in 2 or 3 paragraphs just as to the background and the intents of the Not Every Disability is Visible campaign. The motion also referred to changing places toilets, which are, if you like, super accessible toilets. I'll declare a bit of an interest in this, as I do have a family member, and we can only, when we're out, if she does need the toilet, we can only use changing places toilets. So this is just a couple of paragraphs about what those toilets are and what their features are. As you say, Sarah is here this evening. I did circulate 2 members a briefing note earlier today, but I think over to Sarah to talk about Crohn's and colitis and the Not Every Disability is Visible campaign.
Hello, thank you for having me here this evening. And I just want to also say thanks to Councillor Hamblett for proposing the motion that we're considering. As Mark mentioned, I'm here from Crohn's and Colitis UK, but I'm here with 2 hats on this evening. One as campaigns manager who leads on Not Every Disability is Visible in our campaign, and secondly as someone living with an invisible condition myself, so I have ulcerative colitis. As mentioned, I did circulate some, sent around some notes to Mark, who's kindly circulated, but there were just 3 points, if that is okay, that I would briefly kind of like to highlight to you in regard to it, and then give the opportunity to ask me any questions, if that's okay.
Yeah, that's fine. Go ahead.
Thank you. So the first thing I wanted to do is address why accessible toilets is important to so many people. So I think we've all unfortunately been in the situation where we've needed to go to the toilet very urgently because we've had a stomach bug, for instance. And unfortunately, that is what life is like for Crohn's and people with Crohn's or colitis. And most days, it's literally like turning a tap on. There's no warning. You suddenly just need to go. And for instance, if you're lucky enough to be having a good day, it might be that because of your Crohn's or colitis, you have a stoma bag that you need to change. So in that instance, you know, you need space to lay out kit, you need adequate waste disposal to put the old stoma bag into. And that's just one invisible condition that affects an estimated 500,000 people. But there are actually over 11 million people in the country living with invisible conditions. And the really important point to remember is that because these conditions are invisible and people, quote, look well, the problem is that unfortunately they're challenged, they're tutted at, they're verbally abused, and sometimes unfortunately even physically abused and asked to prove that they're disabled, even though they have a very real and urgent need to use the accessible toilet. But what we do know from surveying is that the general public are actually really well-meaning. I noticed an error in my briefing. It's meant to say that 93% of people who challenged healthy-looking people for using accessible toilets did so because they thought they were standing up for the rights of people who were, quote, actually disabled. So really, education is actually key, because people have good intentions. It's just misplaced. It's just based on an outdated perception of what disability looks like. And that's why the signs are so important, because when people are challenged for using them, they need a sign to point to and say, look, I don't have to just have a wheelchair to have a right to use this toilet. Or they need a member of a local council who've been trained about the conditions to stick up for them in this situation. Or they need another fellow member of the general public to kind of back them up and say, you know, they actually do have a need. So basically what we're trying to do through this campaign is we want to make sure that we don't have to hear about anyone else having an accident because they've been refused toilet access, or having to show their stoma bag to prove that they have a disability. So hopefully that kind of outlines for you why it's so important for day-to-day life and how it impacts lots of people with Crohn's and colitis, but a much wider group of people that sign can appeal to, as anyone with an invisible condition.
Is there anything further that you want to add, Sarah?
Yeah, there were two kind of more points I just wanted to cover, if that's okay. One was on the benefits of getting involved from your perspective, and also what we can do as a charity to support you. So unfortunately, we know from our Life in Lockdown survey that nearly 60% of people were concerned about leaving the house during the pandemic because of access to toilets. And as I mentioned, people face discrimination. 1 in 2 people with Crohn's or colitis have been discriminated against for trying to use an accessible toilet. But what is really interesting is that actually when we surveyed our supporters last year, we found that 83% of people with Crohn's or colitis felt more comfortable visiting a place where the signs were installed. And even more interestingly, 75% of those respondents said they actually made choices on what pubs, restaurants and cafes they went to based on the accessibility of their toilets. So actually people, what we can see is people are actually voting with their feet, partly because they're having to, but these signs actually bring people with invisible conditions into spaces and most importantly make them feel comfortable. And obviously we haven't run this survey in regards to councils yet, but in regards to pubs, restaurants and cafes, 75% of people were making choices based on toilet accessibility, which I think is really interesting and could really kind of help drive people into local businesses, obviously, you know, in line with government recommendations around the pandemic, etc. But hopefully that gives you a sense of kind of the benefits to Oldham in general of being involved. Yeah. And in terms of supporting you, we have rolled these signs out with all the major supermarkets, travel hubs, pubs and restaurants across the UK. And we've supported them. So we do have temporary, not every disability is visible signs that we are able to provide. But for most of those companies, what we've done is we've reviewed the signs that they've created just to check they're in line with the spirit of the campaign, because a lot of places want them to be within their own brand and have kind of their own designs for it. And we did kind of briefly speak with Simply Signs who work in the Oldham area, and you might see in my note that they suggested that kind of the cheapest they could do that for was £12.50, and actually the majority of that is the installation cost rather than the cost of the sign itself. So I just wanted to kind of give you a steer as to actually it's a relatively kind of cheap thing to be able to do to support people within the community. And we also, around the point of training staff, have lots of materials, videos, presentations, leave pieces that we'd be happy to provide to the council to help train staff about the conditions. And we also have a local group of volunteers in the South Manchester area. So if you did kind of want to take this forward and potentially form a working group to support with the installation and the training of staff, I've spoken to our volunteering team and they're sure that people with the conditions in that South Manchester area could potentially support with that. So yeah, hopefully that gives you a bit of a sense of how we could kind of support from our side. So thank you for listening and happy to kind of take any questions you might have.
No, thank you for raising our awareness about obviously this important issue, and personally I think the council should take a lead on it. Are there any comments or questions from any members? Councillor Alias?
Yeah, Chair, all I was just thinking of whilst I was reading the paperwork and also listening to Sarah is that, you know, once you put these signs on the toilet doors, I don't know if anything will change, to be honest with you, because you know, if people still get abused, you know, if they're not in a wheelchair or not sort of a physical disability that is apparent, people still, I reckon people still get discriminated and abused. But as Chair said, I think it is a really important campaign, and I think the council should fully support it. I fully support it, but I'm just wondering whether just the signage will make any difference to what's actually happening at the moment.
I think, oh, sorry.
I think what we should obviously just to come in on Councillor Alias's point of view, the signage is important, but at the same time, as you mentioned, Sarah, in terms of raising awareness as well, we need to run a campaign, obviously with the council staff, but with the voluntary sector as well. And I say with Action Together, if we can sort of link up Sarah with Action Together, and that way we'll be able to sort of raise this within the community groups, and that way get it out to the general public as well. So do you want to come in, Sarah, or shall I bring Councillor McLaren
in? Well, just to add to what you've both said, Chair, this is obviously something that we would wish to take forward. A question to Sarah really is about the 30 million. It talks in here on page 66, 2.6, about a £30 million fund to install changing places in existing buildings, etc. As to how we access that fund, or whether she can help us if that was the case, if we were able to take it forward. So I think it's in 3 stages, this, Chair. We've got to find out, A, which toilets the council own, as it were, that are suitable now, that could accommodate the signage, and which buildings would need adaptations, etc., in order to make the change possible. But given the state of the council's finances, etc., we would probably need a grant from, you know, I don't know, back to the 30 million. It reads here, to implement the above amendments to the building regulations, approved document document M, access to and use of buildings, was published in July 2020. A 30 million fund to install changing places in existing buildings was also announced. Whether Charlotte can help us with that?
Chair, I wonder if I might come in at that point. The motion did seem to talk about accessible toilets and changing places toilets together. I think there is a difference between the accessible toilets you normally see, which have the wheelchair logo on.
Access, right? Yeah.
And then the changing places toilets, which are toilets for people with significant disabilities, and which are provided with ceiling track hoists, changing beds,
right,
and the like. And that fund of £30 million is geared towards the provision of changing places toilets.
Right. So it's not so, right. So if I'm understanding you correctly, Mark, this wouldn't help us necessarily with the issue that Sarah's discussing with us.
I think
There's two prongs to this, isn't there? So obviously, there's the accessible toilets aspect, which I think most public buildings should be able to accommodate, because you just changing the sign into, isn't it? Because most toilets are DDA compliant, and they'll probably meet the accessibility element that Sarah's alluded to. But the other ones, the other element to it is obviously where we've got, I don't know whether in terms of shopping centres could accommodate those, and within Oldham we could suggest or make a recommendation to the cabinet to say look at spindles or something like that, and apply for that grant. We won't be able to do it in our offices obviously, but in terms of having at least one or two of those facilities available within the Oldham town centre itself, will probably go a long place. So in terms of moving forward, I think, Sarah, do you want to add anything else, or before we make a recommendation?
Just very briefly, Councillor Alias, yes, your point around kind of will it make a difference? I think we've got to kind of view it as a step change. I think putting in the signs is the first thing. And interesting, we do know that it does make people feel more comfortable. It doesn't take away the fact that they might still be challenged, but it's having that visual resource that they can point to and say, actually, you know what, I can use this. Does give people confidence. And I think, as you all say, it goes hand in hand with also training staff. We can't just be putting signs up without kind of educating people, because we can't expect people to understand unless it's explained. And I think on the changing places point, that yes, my understanding, although I don't kind of lead on the changing places bit from Crohn's and Colitis UK, is that funding is in regard to any new changing places toilets that are built going forward. So as you say, it's separate to that, to the accessible toilets. And I think the issue of the accessible toilets can be solved kind of with signage and with training, and then the changing places kind of is that separate fund for new changing places toilets.
Thank you for that. Councillor McLaren, did you want to come back in?
Well, just to, I mean, as you say, Chair, it's just a question of how we take this forward. Maybe we need to have an hour outside this meeting just to formalise, if you like, what we're trying to do, rather than trying to put together.
I think we've got most of it in place, Councillor McLaren. My sort of recommendation would be to actually, at this stage, is obviously in terms of the accessible toilets element, if we can put that to the relevant cabinet member and officers to go away and look at it, see how much it will cost us to make those necessary changes, and if they can come back to us, and then we can form a report to move forward. And then obviously on the changing places point of view as well, again, if the relevant cabinet member and the supporting officers could sort of cost that up, see if we can provide it at spindles. That'll be my suggestion at this stage, and sort of they can apply for the relevant grants, and say if the grant does come forward, then we could go ahead with that.
Okay.
Is that members happy with that?
Chair, and of course we've got the contact details, so the cabinet members and relevant officers have got the local Crohn's and Colitis UK representatives to consult with as they're taking it forward.
Right.
And if they want us to meet up with them to sort of a subcommittee to look at some of these issues, then we're available.
Yeah, that sounds like a plan, Chair. Yeah.
Councillor Bird. You're on mute, Pam.
I know.
You're on mute again.
Apologies for being offline. I don't know how it happened. I'd made notes before when I'd read the brief to this. I'm sorry to have missed most of it. But I want to take the signage issue to the parish council. Are we on the colitis and?
Yeah, we are.
Yeah, because we fund public toilets in different buildings, in pubs and cafes and things. And so I'd like to take that to them if somebody can send me more details on the signage.
Yeah, Mark will sort of help you on that.
Thank you very much. I'm sorry I missed it. I didn't mean to. Just there we are.
It's okay.
These machines.
Yeah. So we've got a plan forward there then. Are members okay with that?
Move your recommendation, Chair.
Thank you for that, Councillor McLaren. So that's agreed. Is that agreed with everyone? Okay, thank you. We don't really need a vote on that, do we?
No, Chair. I think that looks with general assent.
Yeah, Sarah, thank you for your time and for joining us this evening. And if we do need any more help and support and advice, I'm sure Mark will be in touch with you. And all the best for Christmas and the New Year.
You too. No, thank you ever so much for your time. And yeah, as you say, if you do need any support from us or putting in contact with other people with the conditions, then please just give us a shout. More than happy to help.
Definitely.
Thank you ever so much.
Thank you. Bye.
Thank you.
Thank you.
Thank you.
Moving on to item 13, which is the Health and Scrutiny Committee Work Programme. Mark, do you want to present the report to us?
I think the report is self-explanatory. I think just highlighting one or two points as we go along. A number of members did attend a Making Safeguarding Personal session in November. I've received positive feedback from that session, and there's going to be work to look at, including a similar type of session in the member development session. There is a paragraph 1.5 to the report, an update on the chatty checkouts and cafes council motion that you considered in July, a brief update in the report, and future updates on that issue will come as part of the Thriving Communities and Health Improvement periodic report that you receive. And I've currently been discussing with Peter Pawson, the relevant manager, there may be bringing a further update on that to the January or March meeting. And then looking at the work programme, you touched on it again this evening, but a couple of times already this municipal year, you've had raised issues and raised concerns about digital inclusion, and there is work going on in the council and among its partners.
Yeah.
And so we've commissioned a report to come to the January meeting, rounding up some of the activities which are going on to ensure digital inclusion. And then obviously arising from tonight, I think there's several significant pieces of work which may very well be coming out of the primary care item, a follow-up to and further update on the learning disability strategy implementation around this time next year, and a further report back on the accessible toilets issue.
Yeah, this work programme's getting bigger and bigger, I think. We need to.
I would say as well, we have managed, and behind all that is of course in due course that there is also public health business to work back into the work programme.
Yeah. Is there any comments or questions on the work programme? Councillor Alias, you got your hand up? Or is that from before? Right, okay, he's stuck it down now.
It's Chair.
Right, so thank you for that, Colin. So next, item 14 is basically the next meeting, which is in January, 26th of January at 6 p.m. This is the end of the meeting. I would like to thank you all for staying with us this evening and for your contribution. Obviously, I'll see most of you again next week, but probably won't see Mark, Laurie, and the new image guest, whoever it is. So all the best for Christmas and the new year, and stay well and stay safe. Thank you.
Okay, thank you very much.
Thank you.
From